so no financial interest. So my talk is on proptosis, how to approach. So basically the questions are, what is proptosis? You know, when the eye is protruding out, it's proptosis, and when it's going in, it's ophthalmos in simple terms. So the question is like, okay, there's proptosis. What is happening here? And it is axial or non-axial. If the eye is turning down, medially, laterally, or superior, so where's the lesion? Whether it's anterior, posterior, which location? And the salient question, why is it happening? So, if you know, like the posterior causes of a proptosis. So something is pushing from behind the globe and the eye is moving forward. So it can be axial or non-axial, and anterior ones. So then you might be able to palpate a lesion, and it's more common. The eye is deviated with even a small lesion, and they might be associated periocular signs. So there are a few pictures, and if you see here the eye is moving. It is proptosis, and the lesion is over here. So, and in this one, so the eye is moving down with proptosis. So the lesion is in the supratemporal. So you can see if the eye is moving this direction, the lesion is on the opposite side. And next one is a bilateral proptosis case. So in a child, what are the causes? Whether there are systemic associations, you have to think of. And then whether it is associated with inflammation, pain, and in a medial lesion, the eye is moved laterally. So you have to know the adjoining locations where it can come from. So you have the frontal sinus over here, and then the brain and the mucoceles can come from here, and then the maxillary sinus, ethmoids, and you have the orbit, and you might be having associated periocular signs. So the most important thing is like when you see a proptosis, whether it's a true proptosis or pseudo proptosis. So inspection is the key. With inspection, without touching the eye, you can come to a differential diagnosis and what is happening in the eye. So you have to have a set routine in examination in all these patients. So there's no one set pattern, but you have to have your own way of finding. Even in the exam, you have to have a clear flow of doing things. So next thing is whether it's dynamic, whether it's proptosis all the time, or does it change with your position, Valsalva maneuvers, and then whether it's kind of a pulsatile. So those are the things that you can observe. So as you know, the positional things are the orbital varices. So sometimes you might find a proptosis at time and sometimes in ophthalmos. And meningiomycetes, meningiocele and meningomycetes are important differentials you have to think of, because if you happen to plan surgery without thinking of these things, then you might end up in trouble. Then pulsatile things. So you know keratoconus fistulas, and there is a pulsation and AV malformations, and neurofibromatosis, NF neurofibromatosis type 1, there might be bony defects that might transmit the impulses to the eye. Meningioencephalocele and trauma also, there are bony defects that can transmit. And the time dependence, whether it changes with time. And not only the eye you have to inspect, you have to look for periocular things, ecchymosis. Ecchymosis is a very common presentation in malignancies, secondaries in children, especially neuroblastomas and some osteosarcomas, sometimes eosinophilic granulomas as well. And adults, if you see meningiomas, you will see the temporal fullness mostly. So in your orbit case, if you see always young person, so you have all these differentials, but just in the corner of your mind, just make sure you see the periocal things when you inspect before you start talking about the case. And this, so going into few cases, you can see this is a case of neuroblastoma. So you can see how the raccoon eyes, like bilateral, commonly in the 2 to 3 years of age. So if you have bilateral, it can be, you think of child abuse, non-accidental injuries. In this age group, don't know their social backgrounds, but make sure that you don't send the child back, but you have to refer to a pediatric colleague. So you might have to do ultrasound scan. And we have seen few cases, like when I was with Chamira as well as when I was overseas, there was a few cases which presented as bilateral ecchymosis. And xanthogranuloma in an adult, I see the periocular fullness. So it has proptosis, orbital involvement, as well as periocular changes. And these are some other tumors where you have periocular changes. You can see the fullness over here. So it's a lacrimal gland lesion which has extended into the orbital region. And then also notice where there are lymph nodes. So lymph node can be associated with infection, inflammation, lymphoproliferative diseases, and histiocytic lesions. So now still you haven't touched the patient, but you have noticed what is happening, so you have a vague idea of what is happening. Then you have to check for eye movements in all positions, all gazes. So reduced function, or it might be a restriction of movements. So it can be the muscle involvement, or it can be nerve, orbital involvement, or outside. So the causes can be inflammation, infection, vascular, or tumor causing this. And of course, in orbital lesions causing proptosis, can be in orbital apex involvement and causing problems with orbital apex syndrome as well as superior or inferior orbital fissure syndromes. So restrictions in eye movement can be the nerve problem, or can be myositis, infiltration of the muscles, then metastasis, then fibrous haematomas causing the eye, the muscles not to move, and linear sclerodermas. And if you see linear sclerodermas, you will find, like, it can be fibrosis, and there might be associated scars around the eye. So which compartment? It's whether it's ocular, intracorneal, extracorneal, and what are the causes? So if you happen to, always don't go for a definite diagnosis, it has to be a differential. You might be wrong always. So always, any case, it can be a vascular, infectious, inflammatory, traumatic, neoplastic, idiopathic, congenital causes. So if you happen to think of a cause, you have to know that you are not on the right track. So always revisit the diagnosis, always. Then palpation, of course, in proptosis case, you have to palpate around the eye, trying to find a possible palpable lesion. And pediatric and congenital cases, so it can be conjunctival orbital cyst, teratomas, posterior dumbbell dermoid, capillary or cavernous hemangiomas. So first you think of secondaries in children like neuroblastomas, Ewing sarcomas, but of course it can be some congenital ones as well, which sometimes present a little late. So always have this kind of back of the mind, what is happening. You might be right, you might not be right. So these are the few cases that I've come across. So this case I've presented a few times. So patient came with after fall, retroorbital hematoma, and people was not reacting, transferred from my colleague from in the central province. And importance of before going into any surgery. So the plan was to do a lateral decompression, or sometimes to do a medial and inferior decompression if it doesn't sort out. So luckily, just before entering eye, like we managed to do the basic blood, and there was a huge hematoma behind, and it was APTT was high, so it was a factor 8 deficiency. So always before embarking, so do the basics always in the orbital before surgery. So it's always important, like look beyond the normal causes, you might be wrong. So next one is a child with 1.5 years, proptosis, unilateral, white eye, seeing eye. So this was a tumor. So I did a biopsy, and then first it came as a neuroblastoma secondary, hopefully, but then when we referred the patient to the Maharagama Cancer Institute, then it was a Ewing sarcoma, and initially the plan was to remove the eye, but luckily we managed to salvage the eye. Probably you've heard about this case in a previous session. So there are many more differentials. So and in a proptosis case, so these are the basic unilateral or bilateral. So commonly always it's thyroid eye disease is the first differential diagnosis. There might be other causes like this. So issues in proptosis. So anxiety for both clinician as well as the families, and the visual potential, and if you do surgery or otherwise permanent disfigurement, so do you need the surgery or not, and if it is a cancerous thing, whether it's there. So you have to address all these things. So make sure you take time, talk to the patient, have a time to talk, and spend time to discuss the matter with the patients as well as your colleagues. So multidisciplinary meetings are paramount important. So whatever the litigation issues can be divulged, hopefully, if you make a combined decision. So examination, so you have to do the basic examination, inspections, palpation, and also do the slit lamp examination, eye pressure measurement, do the proper fundoscopy. So that's the basis of, so not a very theoretical, but you have to think out of the box. You might be not right all the time. So next time, approach logically, and it might be a simple proptosis or it might be something complex. So thank you.